Hi, I'm Sophie Weston from Menzies School of Health Research. In this video, I'm going to take you through adverse events and serious adverse events in malaria clinical trials and how to report them. Good clinical practice guidelines specify that in a clinical trial, participants' well-being and safety must be protected. Study staff should assess all local safety events and should act on any events as clinical care dictates. The role of the investigator with regard to safety reporting is to provide the sponsor with all relevant information so that an appropriate safety analysis can be performed. The sponsor and the Independent Data Safety Monitoring Board will monitor adverse events and recommend changes in the protocol or operation of the study if necessary. According to good clinical practice, an adverse event is any untoward medical occurrence in a patient administered a pharmaceutical product and that does not necessarily have a causal relationship with this treatment. An AE can therefore be a new symptom or disease after the patient is enrolled in the study or has taken the study drug. For example, nausea, vomiting, abdominal pain. Also, any worsening of a medical condition from baseline, for example, headache, and abnormalities in laboratory results or in a physical exam. To report adverse events, all AEs occurring during the administration of study drugs, whether or not attributed to the study drug, will be recorded in the case record form, or CRF. All AEs until day 42 should be recorded. All AEs should be followed until resolution. And all AEs will be graded by severity. We will look at the severity grading now. Grades refer to the severity of the AE. Grades 1 through 4 contain unique clinical descriptions of severity for each AE based on the following general guidelines. Grade 1 is mild with no or mild symptoms and no intervention required. Grade 2, moderate, minimal intervention required, and some limitation of activities. A Grade 3 AE is severe but not life-threatening, hospitalization required, limitation of a patient or participant's ability to care for him or herself. And a Grade 4 is life-threatening with urgent intervention required. The following guidelines describe the relationship assessment between an AE and the study drug. Definitely related is almost certainly a causal relationship exists when the event is a well-known effect of the study drug. It may be listed in the PDR, the investigator's brochure, or device manual, and it follows a clear temporal sequence from the drug's administration. It also would cease with discontinuation of the drug and reoccurs on restarting. It is clearly not related to the study participant or study environment factors. Probably a causal relationship exists when the event is known or a suspected effect of the drug, whether documented or not, and follows a reasonable temporal sequence from drug administration. It ceases or diminishes with discontinuation of the drug and cannot readily be explained by study factors or personal participant factors. Possibly a causal relationship exists when the event is a known or possible effect of the drug, yet follows only a fair temporal sequence from the drug's administration, and it may be explained by participant or study factors. Not related is an unlikely or remote chance that a causal relationship exists when the event is not a known or suspected effect of the test drug or device, is not a possible or known effect of the drug, does not follow a temporal sequence from drug administration and can readily be explained by participant or study factors. So here we have the adverse event form. You can find these in every participant case record form, the investigator site file, as well as available from the site investigator, the team, and the team at Menzies, should you so require. The form is very simple to fill in. Just make sure you fill in every section. What is the AE term here is the symptom that the participant is experiencing, for example, abdominal pain and vomiting. We have the start date and time, end date and time or ongoing. The toxicity grade is the severity grade as we discussed, so grade 1 is mild, 2 moderate, 3 severe, and 4 life-threatening or fatal. There is a reminder here that if it is life-threatening or fatal, this automatically becomes an SAE, and in the next section of the video we will discuss serious adverse events. So we recently went through the relationship to study drugs, and as we said, it relates to the temporal causal relationship you can assess with that adverse event. And finally, we need a short description of the AE. If it is straightforward or if it is longer, please put as much detail as possible. You can also use an additional piece of paper and file that with the CRF and the participant notes. A serious adverse event is any untoward medical occurrence that at any dose results in death, is life-threatening, requires hospitalization or prolongation of hospitalization, results in persistent or significant disability or incapacity, results in a congenital anomaly or a birth defect, and any other important medical event requiring medical intervention to prevent one of the outcomes above. AEs and SAEs overlap. An AE grade 4, life-threatening, is always an SAE. A fatal event is always an SAE. An AE of grade 3, severe, can be an SAE if the participant requires hospitalization. We define hospitalization as a participant being admitted for an overnight stay. A short stay for socioeconomic reasons or personal reasons is not considered hospitalization. In our specific studies, we use primaquine, and in particular studies, tefenaquine, and we have some study-specific SAEs that are immediately notifiable to the Menzies and the site investigator team. So any participant who has a requirement for a blood transfusion, a hemoglobin of less than 7, and a urine colour of greater than 5 on the Hillman scale, a fall in HB greater than or equal to 25% from baseline, and a urine colour of greater than 5 on the Hillman scale, acute anaphylaxis, and persistent vomiting that requires hospitalization for IV fluids. Once you have identified an SAE, it's important to complete the AE form with all required information, as well as the following serious adverse events form. This SAE form is an added form and it is submitted alongside the AE form. It contains information about the classification of the SAE, the admission date and discharge date if the participant required hospitalization, and a detailed description of the SAE. Now we'll talk about how to report the AEs and the SAEs. So the AEs are recorded in the CRF and no further action is required. The SAEs are reported within 24 hours to the Menzies Principal Investigator, Kamal Al-Thrimer, and we require as much information as possible. You can use additional blank pages and just attach those to the CRF when filing. Follow-up information can be sent anytime. That includes discharge summaries, medical reports, drug medications that the participant has been administered, and it is the responsibility of the site PI to report to the Institutional Research Board and Ethics Committee. From our side, we will inform the Data Safety Monitoring Board within 2 to 3 working days for any SAEs that are definitely or probably related. We also have further information in the Standard Operating Procedure on SAE reporting, but the biggest take-home message is to A, identify the SAE, and B, report within 24 hours after occurrence. One of the biggest risks in our clinical trials is the risk of hemolysis. This is due to the nature of our clinical trials. As you're aware, malaria can cause hemolysis. Primaquine and tefenaquine treatment drugs used in our clinical trials can also cause hemolysis in G6PD deficient individuals. Severe hemolysis and anemia in a participant is likely to result from a variety of factors, including the severity of G6PD enzymatic deficiency, the dose of primaquine, the degree of parasitemia, and nutritional status. Detecting hemolytic events requires monitoring of the participant condition. On enrolment, it's essential to encourage participants to come back if they don't feel well or have dark urine. On each follow-up visit, check for anemia. This includes a hemoglobin measurement, a urine sample to assess for dark urine against the Hillman scale, pictured on the right, and also a symptom assessment for breathlessness, shortness of breath, any other symptoms that may indicate a clinical deterioration and hemolytic event. Warning signs for hemolysis can be recognized by the following: macroscopic hemoglobinuria, Hillman score greater than or equal to 5, or a fractional hemoglobin fall greater than or equal to 25% at baseline, or significant clinical concern with regard to anemia and hemolysis assessed by the attending clinician. We encourage you to be precautious and on the safe side, and we have no issues with you contacting us or the site PI anytime if you have any clinical concerns about a participant in the trial. A hemolytic SAE is any of the warning signs in combination, and a hemolytic SAE needs immediate clinical intervention and reporting to Menzies within 24 hours. A hemoglobin of less than 7 plus macroscopic hemoglobinuria, which is a Hillman greater than or equal to 5, anyone requiring a blood transfusion, or a Hillman greater than or equal to 5 plus a fractional drop in hemoglobin greater than or equal to 25% from baseline is a reportable hemolytic SAE. To manage a hemolytic SAE with any clinical concern of acute hemolysis, for example, symptoms of anemia, dark urine, clinical jaundice, or falling hemoglobin, breathlessness, should trigger the following: a thorough history and examination, an immediate hemoglobin measurement, Hillman urine colour estimation for hemoglobinuria, repeat G6PD testing using the biosensor, and contact the study team, the site PI, and also the Menzies team. Here at Menzies, we have made a management of hemolytic SAE decision tree to assist clinicians to assess whether primaquine needs to be stopped. So primaquine and treatment needs to be stopped if the patient needs a blood transfusion. If they have a hemoglobin of less than 7 and symptoms of anemia which is limiting their daily activities, or a hemoglobin between 7 and 9 and clinical decompensation due to anemia. An indication to withhold primaquine is a hemoglobin of less than 7 but daily activities are unaffected. They may have a macroscopic hemoglobinuria or a Hillman of greater than or equal to 5. They may have a fractional hemoglobin fall of greater than or equal to 25% from baseline, or any other significant clinical concerns of anemia or hemolysis. And remember, any of those warning signs in combination will trigger a hemolytic SAE and immediate reporting to the Menzies and site teams. Sorry. So in the following 24 hours, a decision will need to be made if primaquine will be withheld further or redosed. So clinical review and hemoglobin measurement daily or more frequently, and routine follow-up will be continued. So if the hemoglobin falls or drops over the preceding 24 hours, we'll indicate whether primaquine should be withheld further or redosed. A fall greater than 1 will indicate to withhold primaquine, and a stable hemoglobin can be redosed at the discretion of the clinician. In case of a patient with warning signs, recheck the G6PD status with the SD biosensor. If the result indicates that a patient is deficient, stop the treatment, contact us here at Menzies and the site PI, and if the patient is severely unwell or has a hemolytic SAE, refer them directly for immediate medical care and follow management and hospital protocol as well as SAE protocol. That concludes the safety video today. You can get in touch with us at malaria@menzies.edu.au, or the principal investigator, Dr. Kamala Thrimer, or myself, sophie.weston@menzies.edu.au. Thanks.